Good evening, everyone. Thank you for joining us for the Middle East Professional Education webinar series. Today, thank you for attending this webinar. Today, we're talking about optimizing embryo transfer technique to help ensure the best outcome. It's going to introduce by Steve Levitt, the Director of Clinical Application Scientist at Cooper Surgical. Steve, over to you. Thank you.
Thanks, Badur. I'll start sharing my screen. Okay, so thank you everybody for joining. You probably saw from my bio that was on that previous screen. I'm an old embryologist, been in the field for a very long time, and from the earliest times as an embryologist, it became quite apparent that embryo transfer is one of the most critical procedures that we carry out throughout the whole IVF process. So it's one of my favorite topics to speak on. It's impossible to cover every aspect of embryo transfer and all of the things that make a difference, but I will try to pick out the highlights for you and hope that some of the information reaffirms what you do and reassures you, and maybe some of the information will be new and will give you something to consider in your practice back in your own clinic. So I'm going to share the agenda. So we're going to talk about a bit around good lab practice, some of the guidelines and regulations that exist, and then you can see from the rest of the agenda, we're going to go through specific aspects of embryo transfer that play an important role in success, and then summarize at the end. So we'll start with guidelines and regulations and looking at good lab practice. And there's lots of publications out there that give us some guide, some information about how to achieve optimal results. And you can see just a few of them on the screen. So some from big organizations like ESHRE and ASRM, and then some from local guidelines. And hopefully in all of your own areas, there are some local guidelines that will help you determine what is the best practice for embryo transfer, or at least give you some of the regulatory guidelines that you need to follow. When we read through all of these, and some of you may have seen some of them, some not, what they don't do is they don't tell us how to do an embryo transfer, which would be great if they did. So somebody would come up with a standard protocol that we could all follow that would give us the best outcome. But there are so many variables that around the world, there is very little agreement on what constitutes a perfect embryo transfer. There are some key points that we have to follow, but within that, it gives us some variability to work within our own parameters in our clinic. So these are all good to help us understand what the bodies recognize as key factors, and then we can choose one or two of them. And I'm going to choose the big ones from ESHRE and from ASRM, just to give you a feel for the sort of information that they give you. So just picking out some of the highlights from the ESHRE guidelines from 2015, and they were upgraded in 2022. But you'll see, if you just pick some of these points out, embryo selection for transfer is based on morphology, which most of you do. Then there are other selection parameters, including time lapse. It may be that we do genetic testing to isolate within a population the best embryo for transfer. ESHRE particularly, and countries within Europe for many years now have tried to encourage IVF units as much as possible to try and do single embryo transfer to reduce the risk of multiple pregnancies. And indeed, where I was working in the UK, a multiple pregnancy following an IVF treatment cycle is now regarded as a failure, not a success. Now, if we ask patients what they want, they'd love to have a healthy twin pregnancy. If we could arrange it for to be a boy and a girl, they'd be extremely happy. But of course, that makes the assumption that they will have a healthy pregnancy and a healthy birth and healthy children born from it. And we know that multiple pregnancies increase many risks. So in general terms, the guidelines are pointing us towards moving towards single embryo transfer. And certainly if you look at ESHRE, they make this last point, it is advisable not to transfer more than 2 embryos. So we should be aiming for 1, and in some exceptional circumstances, we may consider 2. Now, this isn't universally applied, but in Europe, it's getting quite strict. And for funding from governments, if you want to have treatment, then you have to abide by these guidelines and you have to have single embryo transfer. Again, we move on a little bit for the transfer procedure. They don't give us any specific instructions. They give us guidelines about what we should note in the patient's chart. So date and time of the transfer, etc., as you can see here. Key is what happens to embryos that are not being transferred, what we're going to do with them, whether we're going to culture them on, etc. And we should make note of what happens during the embryo transfer procedure, so that if the patient requires subsequent treatment and subsequent embryo transfers, we've got some guidelines about what we might need to do the next time. So whether we've seen blood, whether we've encountered retained embryos, whether it was a difficult transfer, what needed to be done to actually facilitate the transfer. That might help us a subsequent time if we need to do that. If the lab is some distance from the embryo transfer room, arrangements should be made to maintain temperature and pH while transporting embryos. This can be a problem in some facilities. New labs, new IVF clinics tend to take this into account. We don't all have the luxury of working in new clinics, so we need to mitigate for that if it is the case that the lab is a long way from the embryo transfer room. And as always, and we'll talk about this a number of times through the presentation, witnessing, traceability, etc., are extremely important. You know, we've all heard of the stories where patients have had a mix-up on somewhere along the line. They're not always around embryo transfer. The error may have occurred earlier, but if a patient ends up giving birth to the wrong genetically sourced baby, then it's obviously catastrophic for the patient. It's a huge issue for the clinic and everybody involved. So witnessing is a key factor, and traceability throughout the whole process. Yes, our guidelines are the same. They really don't tell us in detail what to do. And again, they provide guidelines about various factors, including, again, that they believe elective single embryo transfer is recommended. And if we can achieve that, particularly in the US, where the significant number of cycles include PGT. So if you're putting a euploid embryo back, then, you know, again, consideration needs to be given on the number that you transfer to avoid multiple pregnancies. They do say and recognize that there's no standard protocol. So each laboratory may have unique variations in their SOPs pertaining to what sort of culture and embryo transfer media you use, what plasticware and consumables, what sort of catheter, how you load the catheter, etc., etc. So they recognize, I think, that there's no standard here that everybody follows, and they give some leeway to organize things in your own clinic in the best way that you can. The laboratory must manage and organize a daily schedule to optimize workflow and workload and ensure that a doctor's orders and signed consents are received. So again, this is important that everybody knows ahead of time what's going to happen, that the list of patients coming through is maintained, that we don't have changes, and that things are done on time, ideally, which doesn't always work out, as we all know. But these should be things that we strive for in best practice. Embryologists are responsible for the dish setup and maintaining optimal conditions. The time of embryo transfer, as we all know, is an acutely sensitive time where obviously the correct embryo selection and identification and all of those factors are extremely important. The patients have invested a lot of time, money, emotion into getting to this point, and we need to make sure we get it right. We do a good procedure, but also all of the other factors are in place. And to that extent, the last point here, embryologists would typically perform a timeout procedure, so we can verify that all of the information that we have is correct. So we've got the right patient, we've got the right embryo at the right time, and everybody's ready to go. So again, they're not helpful in teaching us exactly how to do the transfer, but they're setting the scene so that we have everything in place to make the transfer as successful as possible with the right embryo at the right time for the right patient. The ASRM go a little bit further. They have some clinical standards that they set. Interestingly, you can see from the bullet points on the right that this is an opinion. So unlike some of the other guidelines that follow published data, this is an opinion of experts in the field. They did use some data to do that, but they were focusing on clinical aspects from only 5 medical directors. So again, a very small number of people that are involved in the field come up with a committee opinion, and it's very hard to read on the left-hand side there. But I encourage you to have a look, and it talks about some of the clinical aspects that they believe are important in embryo transfer itself. And just continuing here, we can share the slides in a PDF form with people afterwards, so you don't need to write all of these things down, and you can have a look at them at your leisure later. So the laboratory strategy following on from those guidelines is fairly standard, that we need a standard operating procedure that's robust, that we can use. We have a plan for each patient. We've discussed ahead of time the number and the quality of the embryo that we're going to transfer. We've also made a decision, and we've communicated this to the patient before they're in the operating room, what's going to happen to any remaining embryos. Are we going to keep them in culture? Are we going to cryopreserve them, discard them, etc.? And of course, we should have had a plan to discuss with the clinical team exactly what's going to happen. In those countries where it's appropriate, consent forms need to be filled in. And of course, we confirm everything with the patient, but nothing that we discuss at the time of embryo transfer in the operating room should be new to the patient. It's only confirming what we've discussed before. And again, just to reiterate, traceability at all steps during this procedure. So the embryo and the transfer. When I started my embryology career a long time ago, we only did cleavage stage transfer. It was very unusual for labs in the early 90s to do blastocyst culture and therefore blastocyst stage transfer. And when I was training as an embryologist, we were told the one stage we couldn't do embryo transfer was on day 4, the morula stage, because it was very hard to identify the best quality embryo. But that's changed now, and there are labs doing successful embryo transfers on day 4 with morulas. Of course, we can do fresh or cryopreserved embryo transfers, and we'll discuss in a little while the merits of both. An increasing number of embryos now have been biopsied for genetic testing, and that may mean that we have embryos that have intact zona, that are hatching or fully hatched, i.e. zona-free embryos. And so there's a large number of different stages that we might and conditions of embryos that we might consider. And embryo selection, as we mentioned in one of the earlier slides, traditionally on morphological aspects, developmental events, we now see morphokinetic parameters for embryo selection. We could add in here PGT. In the future, there may be other parameters that we use to select the best embryo for transfer. Again, each lab will have their own criteria and their own methodology, but the greatest indicator of success in embryo transfer is transferring a good quality, healthy, genetically normal embryo. If we have those, we're well on the way to success if we get the technical aspects of the transfer right. Which stage is better? We've generally moved now as an industry, as a profession in embryology, to doing blastocyst stage transfers, partly driven by the desire in some places to do genetic testing, but others because they believe it's a better way of selecting embryos. But when you look at the data and the published data, a relatively small number of randomized control trials give relatively low quality evidence in favor of blastocyst transfer. And when you look at clinical pregnancy rates, there's only moderate quality evidence in favor of blastocyst transfer. And it's not clear whether blastocyst transfer improves the cumulative pregnancy rate derived from fresh and frozen cycles following a single egg collection. So an interesting discussion whether we transfer cleavage stage embryos or morula or blastocysts. If we're going to do blastocyst transfer, one of the key factors is that we have our culture system optimized. The longer the embryos remain in our lab under our control, the more critical that the conditions remain optimal over that extended period of time. And that's a whole different discussion, a whole different topic. But if you want to do blastocyst stage transfer, it will only be successful if you have good quality blastocysts. So that introduces another factor into the equation here. Fresh or frozen, again, through circumstance, people's belief that frozen embryo transfer might be better, and partly again because of genetic testing, we've moved quite a long way towards doing freeze-all cycles. So it's interesting to look whether that has any meaningful evidence to support it. And as you can see from this side, 15 studies in this systematic review and 8 studies otherwise, with a total of 4,500 women in a meta-analysis, moderate quality evidence showing that one strategy is probably not superior to the other. So this doesn't support strongly one strategy or other, whether we do fresh or frozen. And remember, of course, the difference between a fresh and a frozen cycle is just one embryo transfer, because all of the remaining embryos that are good quality are going to be cryopreserved and done and then replaced in a frozen embryo transfer cycle. So the difference between the two is only one fresh embryo transfer. So other patient groups, particularly those at risk of OHSS, which thankfully is a much lower risk than it used to be in the early days, may obviously benefit from a freeze-all strategy. If they don't get pregnant, the risk of OHSS is decreased. So for them, a freeze-all strategy is perhaps the best. And we actually have been doing that since the mid-90s for example, PCO patients. There were some study limitations. They couldn't look at the time to pregnancy. And we've known from the very early days doing frozen embryo transfer that there are some risks associated with transferring cryopreserved embryos. It's low quality evidence, but it has been recognized for quite some time. This is way before vitrification. So there are some evidence, some papers that suggest maternal hypertensive disorders in pregnancy are increased. I think the bottom two here are probably not controversial. We know this, and we've known this for a very long time. So babies born through frozen embryo transfer tend to be large for gestational age and have a higher birth weight than children born without assisted conception or from fresh embryo transfers. So now we have to look about whether our glass is half full or half empty. So we get larger babies, and there is maybe a smaller increased risk to the mothers during pregnancy. So if your glass is half full, you look at the other side of the story, and that is that, of course, if the babies are born with higher birth weights and large for gestational age, it means we have a decrease in the incidence of low birth weight. And in many pediatric and neonatal studies, low birth weight in neonates is sometimes seen as more problematic than large birth weight. So if your glass is half full, you look at it as a positive. If your glass is half empty, it's a negative, because we've got these generally larger babies. We mentioned that there's an associated increased risk of hypertensive disorders. This may be because of the absence of the corpus luteum. In a frozen program cycle, you're not going to have a corpus luteum, which you would have in a fresh or natural pregnancy. The corpus luteum has many functions, and its absence could be contributing to this. Systematically delaying FET does not offer benefits to IVF outcomes, but there are some psychological and emotional issues to take here. Immediate transfer is associated with a non-significant trend to better clinical pregnancy rates. So again, when it's a trend, we always have to be very careful about how we interpret that, and whether we would see the same thing in our clinical practice. And of course, as always, and you'll see in many areas of IVF and embryology, we really need more randomized control trials to answer some of these questions more clearly. Number of embryos to transfer. We've talked about the guidelines, and many places now are pushing hard to get to single embryo transfer for the main reason of avoiding multiple pregnancies. And the decision on the number of embryos based on many factors. Some are dictated by national or local regulations, as they are in the UK, Belgium, and other places like that. Of course, we've got to take into account the quality of the embryo, age of the patient, ovarian response, etc., and the rank of treatment. So whether this is the 5th embryo transfer the patient's had, we could put in here euploidy status, etc. So it can be a relatively complex decision and discussion with the patient, but our overarching aim should be to do single embryo transfer wherever possible. So when we look at some of the clinical guidelines to give us optimal success, as with embryology, there's no international consensus on embryo transfer practices that have been agreed across the board. So everybody that does embryo transfer, particularly from a clinical point of view, believes 1 or 2 or 3 things that they do will offer benefit and a greater chance of success. But we know from the literature and from studies that some things do contribute to this. So operator experience, we'll talk a little bit about that in a second, is important. Whether the transfer is difficult, and if you have a difficult transfer, how do you deal with that? So that would relate to difficult anatomy. So whether the patient's had previous surgery or disease, other factors come in there. The loading technique, we'll talk about that going forward. Speed of injection is something that's very hard to teach, but may have some impact. How long the embryo transfer procedure takes, and ultrasound and its use, settings, etc. So all of these things are considerations from a clinical point of view, some of which we can control, some of which we can't. We can't control the patient's anatomy per se, but we can manage it, and we can still do a successful transfer if we take these things into account. So one of the things that now I think is not disputed around the world is whether we use ultrasound guidance for the transfer. Now, the UK government are very conservative in what they recommend, and so if they have undeniable and unchallengeable evidence, then they will recommend certain, I guess they would be called add-ons at one time into IVF. And there is overwhelming evidence that ultrasound-guided embryo transfers increase live birth rates. And this is what the UK government work on, not on pregnancy rates or ongoing pregnancy rates. They look at live births, to a point where the National Institute of Clinical Excellence in the UK now clearly recommend that women undergoing IVF treatment should be offered ultrasound-guided embryo transfer. This improves pregnancy rates. It's a very bold statement, and they have to have a lot of evidence to back this up, which they have that large body of evidence now. And I think it's indisputable that ultrasound guidance is of benefit. Not everybody agrees, and certainly on my travels around the world, talking to people who do embryo transfer, not all people agree. but the evidence from the published literature is very strong to support ultrasound guidance. If we go back to the previous slide, one of the things that, of course, is important are the ultrasound settings. So if you can't see the anatomy and you can't see the catheter clearly, then ultrasound is going to have less of an impact. So when we're looking to use ultrasound, again, we need to optimize its usage, its settings, to make sure we can see what's exactly going on. And that includes, as I say, the anatomy from the patient, but also the catheter and the ultrasound visibility of the catheter itself. So the settings and the setup, of course, are extremely important. If we talk about the equipment that we see and use for embryo transfer, no different from everything else in the embryology lab and in culture, that we need to use the best quality equipment. It needs to be set up and mapped in the right way. It needs to be maintained and serviced so that we are working under optimal conditions. We will talk in a little while about which embryo transfer medium to use and how we set things up, but needless to say, if we don't have good equipment working around the embryo transfer process, we're not going to get the best results. So be it the workstation, the incubator, the plasticware that we use, all of those things play a part in achieving an optimal outcome. I'm not going to dwell on witnessing, but it's a key factor, again, that we need to ensure. The embryo transfer is a very sensitive time. It's perhaps even at egg collection, the patient is maybe under the influence of the pharmaceuticals that we're giving them and concerned about the egg collection procedure itself. And embryo transfer, they're very much engaged in what's going to happen. And so identifying them and the embryo, etc., is extremely important. But we know that manual witnessing has its limitations. And so electronic witnessing can help us. We still need to be diligent and vigilant, but it can help. And the patient's obviously there. And the more that we can do to reassure them and lower their anxiety levels, the better the chance of success. The quality of consumables, as I mentioned, is important. The plasticware, the syringes, the gloves, and everything that we use, the PPE, is important. That we use things that are not toxic to embryos. One of the things that's happened in the past is that they call it here a cover, but a lid. The inside of the lid of culture dishes are not coated in the same way as the dish itself. So they are not suitable for using biological material in. I know in the past, a lot of people use the lids of dishes for doing ICSI, and they are not treated in the same way. The companies don't do it because they don't expect people to use them where biological material will come in contact with them. So please don't be tempted. Syringes we'll talk about again in a little while, but whether they are containing these black rubber parts, which can be toxic. And if you're using gloves, which you should, make sure that they are not cytotoxic, that ideally without powder, and you can transfer some of that toxicity to the catheter if you're not careful. Of course, the embryo transfer is a consumable that we use in the whole process, and the type and the usage of the catheter is extremely important. So it doesn't matter what sort of catheter people use. It should be soft. Soft versus stiff catheters is well documented that we should use a softer catheter as possible, but they need to be used correctly. And different types of catheters need to be used in different ways. So again, you cannot just switch from one to another and use it identically. There are some considerations with different types of catheter. And if you're going to do ultrasound guided transfers, the catheter itself needs to be ultrasound visible. And that may influence the choice of catheter that you use. And the syringe is an integral part of the whole process. It needs to have a good connection to the end of the catheter so there's no leakage. And we need to use a relatively small syringe, 1 ml or less. The type of catheter, as I mentioned, there's a lot to choose from, but there's absolutely convincing evidence that a soft catheter gives you better results than a stiff catheter. We need to consider what type of transfer we're doing, whether we're doing a 1-stage or a 2-stage, whether we preload the catheter and take it through to the operating room for the person doing the embryo transfer to insert a loaded catheter immediately. So that's one stage. Or we use some technique where we get a catheter with an obturator or a trial transfer catheter in place first. Once the operator is convinced they're in the right place, hopefully using ultrasound, they can then call to the lab and say, right, I'm ready, please load the inner catheter, and we can do it in a two-stage process. An obturator and stylet are different. Stylets are to be used for difficult transfers. An obturator may stop some transfers from being difficult. So they mitigate some of the difficulties of getting through the cervical canal, but they're not necessarily used for difficult transfers. So there's a distinction here between the two. Then you've got to think about the size, as we mentioned, echogenic versus not echogenic, non-echogenic, cost, packaging, and other factors, supply, etc. We often see that the type of embryo transfer catheter used by a clinic and the embryo transfer practitioners within it have developed just over time, and so they use the same one. The people coming in are trained in the same way. It is ideal if everybody in the clinic uses the same catheter and uses the same standard operating procedure. Makes it much easier to track what's happening, to follow individual performance, so monitoring your KPIs, etc. Much easier if everybody uses the same catheter rather than everybody just choosing one that they've learnt on or have a preference for. All catheters can give you good results if they're used correctly. Some have advantages over others, but in any clinic, ideally, everybody uses the same catheter. The syringe, generally extremely cheap, but an integral part and an important part of the transfer procedure. So I would argue nowadays that we always need to use a disposable syringe. We used to use Hamilton syringes, which are reusable. In the embryology lab, we really shouldn't use anything more than once. So single use, disposable material is generally better, which means plastic, not glass. And ideally without the black rubber stopper. These can be toxic, so try to avoid those. A small syringe, 1 ml or less, and it has to have smooth action. A number of times embryologists have asked me, I get the syringe out of the pack and it's a bit stiff and jerky when I'm moving, jerky motion. What should I do? And the clear answer is you throw it in the bin and you get another one. There's no point risking the whole procedure for something that is very low cost and may influence the outcome if you don't get it right. So it must move smoothly, and we need it to maintain its position so it doesn't cause the embryos to drift once they've been loaded. So they need to maintain their integrity. But otherwise, there's a number of syringes on the market to choose from, but that smooth movement and control is key. Now we come to embryo transfer media. I'm sure embryologists are keen to understand, and there's many variables here and many options that you have in terms of embryo transfer medium. What you're trying to do, what you're trying to achieve during the embryo transfer procedure is maintain that physiological optimal condition throughout the whole process. So we need to be careful that we maintain pH, osmolality, temperature. All of those factors are important because you've taken a long time and a lot of care to create the best embryo. You may have done genetic testing to show that it's euploid. And now you come to do the critical stage at the end, and the medium, the choice of medium, the way you treat it, the way you set up the dishes, etc., can have a profound impact on the outcome if it's not done effectively. So we can use bicarbonate buffered media if conditions allow. So if you were using bicarbonate buffered media, so our culture media, whatever, we need to ensure that we maintain temperature and CO2 to keep the pH within the correct range. So it isn't really possible to use bicarbonate buffered media in most cases unless we're working in a controlled environment where we can maintain that. We'll talk in a couple of slides about the use of oil, which might help, but in most cases, if you've got an open area to work in, if you're using bicarbonate buffered media, you need to be extremely careful in maintaining the conditions. We can use a zwitterionic buffer, so HEPs or MOPs or both, which only rely on temperature. They don't rely on CO2. Or we may choose to use a specific transfer medium designed for embryo transfer. So those that contain hyaluronan have become quite commonly used. There is some evidence that media containing hyaluronan improves outcome. It's an interesting discussion point. We haven't got time today to go into it, but what type of hyaluronan use, whether you use low or high molecular weight, what concentration, etc., is something to consider. But the presence of hyaluronan either in low or high molecular weight does seem to work in some instances. In certain circumstances, and if you look at the ESHRE guidelines, some of the specific media that contains hyaluronan is actually not recommended in frozen embryo transfers. So we need to take that into account and determine whether we follow those guidelines or we believe that that will have some beneficial effect. So an important factor to consider here. We also in the past thought if we made the embryo transfer medium more viscous, generally by adding more protein, that might help with the whole process, make the action of the catheter smoother, stop the embryo moving around too much in the endometrial environment. But most of the literature, and certainly now, there's no evidence that higher protein concentrations improve embryo transfer outcome. So something that we don't need to do routinely. There have been some developments recently in embryo transfer, particularly the transfer of vitrified warmed blastocysts. This paper from Japan that came out in 2022 quite clearly showed that the presence of a cytokine in the embryo transfer medium, here GM-CSF, so granulocyte macrophage colony stimulating factor, improved all of the clinical parameters that they measured. So you can see here the clinical pregnancy rate, the ongoing clinical pregnancy rate, and live birth rates were all improved when GM-CSF was present in the embryo transfer media. So this is really quite encouraging that we now have another consideration when we're doing embryo transfer, something that might help us get better outcomes for the patients. Again, just to go into that a little bit more in more detail, this wasn't a randomized control trial. It was a retrospective longitudinal propensity match cohort study. So not of the highest quality in terms of if it was randomized control trial, it would be more powerful. But nonetheless, the results were significant and they showed a significant increase in, as I mentioned, clinical pregnancy, ongoing pregnancy, and live birth rates. It was then postulated, how does a cytokine help during the embryo transfer process and following warming of vitrified blastocysts? The proposed mechanism is that the GM-CSF itself acts as a stress reliever, if you like, and helps promote normal glucose uptake. So it seems to have an effect both at the embryo level and at the endometrium level. It helps with cell survival within the vitrified warmed blastocysts, and is a cytokine that's present in the normal the normal pregnancy pathway, so an implantation pathway. So there is some encouraging data coming out here. We need to gather more, of course, but it may be that this would become one of the standards for embryo transfer in the future. Now, preparation prior to embryo transfer. So once we've got our culture media sorted, we've got a good culture system creating optimal embryos, we've got our setup for embryo transfer with the medium organized in how we're going to do it. How do we prepare? So again, pretty straightforward, and following those guidelines, we need to prepare the media, we need to off-gas any dishes, etc. Prepare the catheter and syringe, and you can read the rest here. Don't need to go through all the points in detail. But as always, preparation is key. If you want to succeed in any procedure that you're doing in the lab or elsewhere, preparation is key. If you get the preparation correct, then the procedure is going to run more smoothly. Traceability, again, just going to highlight it to you because it's extremely important. If you look here at this table that's collated these the data from these different papers, some with huge numbers now. So in this case, this Sturks et al. Paper from 2023 from Brussels IVF, 850,000 witnessing points. And they saw a mismatch rate of 0.25%, despite having electronic witnessing. Because of electronic witnessing, though, these mismatches, of which some were true mismatches and potentially critical, 144 of them, were prevented. So some mismatches that happen are because an old dish is left in the work area, etc., which wouldn't cause potentially a problem going forward. But true mismatches, despite our best efforts, still do happen, and electronic witnessing helps us avoid these going any further and causing any clinical calamities. So again, very low levels here, less than 1%, generally less than around 0.1 or lower. This one was an exception, this 2020 paper at 0.25%. But you can see in all of these papers, there was a potential critical mismatch that was prevented by having electronic witnessing, and each of those could have been catastrophic for the patient or the clinic themselves. So traceability underpins all of our quality in the lab. It relates to all aspects within the IVF lab, and you can see here with materials, data collection, paperwork and records, etc., etc. So it needs to be at the core of everything that we do. Now, this is an interesting one, that communication seems obvious, but sometimes isn't ideal. When we're working, as I mentioned, in this very sensitive time where patients are absolutely invested in the outcome, it's an emotional time for them, everything needs to run smoothly. We need to identify the patient, so take this time out, reassure them, reassert the plan of what we're going to do, confirmation of the number, the quality of the embryos transferred. If you have the ability in your lab and clinic to show the patients the embryos, which many do now, that's of course of benefit. Ultrasound guided transfers sometimes distract the patient. They can watch a screen rather than be concerned about what's going on. And again, if you use ultrasound, there is an occasion where you might see a little flash, where it's actually an air bubble mostly that you see, but still the patients can be reassured that the embryos followed that and going to be in the right place. But one of the things that's important is this synchronization. There has been times where the clinical team have gone into the operating room, got the patient ready, said, okay, I'm ready to do the embryo transfer, and there's no embryologist in the embryology lab. So, of course, you need to have that communication clear. If there's any changes in the list, on the order of the list that the patient's coming through, that's clearly sent to the embryology lab so that they understand. But we're going to synchronize the whole process by how they're going to prepare the patient, whether when they clean the cervix, remove mucus, etc. We don't want a big gap once they're ready to getting the embryo loaded and brought through. So these things are important. Communication between the different functions within the clinic, in not just in embryo transfer, but in all aspects, is extremely important. So how to perform an embryo transfer? As I mentioned, there's no real standardization out there that we can follow. And when you look at surveys that have been done and documented papers, etc., there are some things that everybody does and that most do, but there is no real consensus. So if you take the top and the bottom on this table, the catheter wash prior to loading embryos was done 80% of the time. But the catheter checked after embryo transfer to ensure there was no retained embryos was done by everyone. And there's some variability in between. But there's no clear path that everybody does all of these procedures, etc. And if they're important, of course, the ones that are critical should be done in as many labs and clinics as possible. So the type of catheter and the syringe, there needs to be a discussion on which to use. And it is recommended that we rinse the catheter before loading. But if you look on this one, most do, but there's still 18% here that don't. Flushing has a number of functions. You can see here it's recommended to remove any substance or debris or dry spots inside the catheter. They then won't be transferred into the uterus, but equally they're going to allow the embryo and the catheter to move smoothly. So the fluid will move smoothly. It coats the inside of the catheter. That's why it's important that the transfer medium, or at least what you flush the catheter with, contains protein. And it pre-warms the catheter before you load the embryo. There is no need to warm embryo transfer catheters beforehand. As soon as you open the packaging, the temperature is lost, and there's a risk that you'll introduce VOCs into the lab. So flushing the catheter through is an important factor to consider. Now, we often have a debate amongst embryologists about which is the best way to load embryo transfer catheters. Do we have a complete column, as in A, or in the other extreme example in I here, we just have a little plug of medium at the end, the embryo within a section of medium here, and then the rest of the catheter's dry. So we haven't flushed it through. We've just loaded the embryo in the medium at the end of the catheter. So we either have a full column or we have a mix of medium and air bubbles, etc. When you look at the published data, there is actually no evidence that any one of those is better than the other. So what you choose is important in terms of loading, in many cases, including warming the catheter, flushing it through with a protein-containing medium to make the action of the catheter smooth, and the volume of the medium that the embryo sits in is also important. If you notice, apart from the top one, which it's very in A, it's very hard to see what the injected volume would be here. But in all the others, the injection volume that the embryo sits in is the same. And that's the key factor, that remains constant. And it's not the type of loading that's important, so air bubbles or not, etc. So transfer volumes, as I mentioned, is important. There are very few randomized control trials that help us too much. Surveys showed that most people use up to 30 microliters, and 20 to 30 is more commonly used, but some use more and some use a lot more. If we load with a very small volume, we run the risk that the embryo will not move away from the end of the catheter. If there's mucus or blood there, it might be affected. And we also know that large volumes can also be a little bit problematic in terms of maintaining the embryo within the implantation area that you want to leave it during the transfer. So getting the volume in the right region, the right volume approximately is important. What we don't want to do is take time to load an exact volume. So somewhere between 20 and 30 microliters seems to be optimal. I mentioned before about which type of embryo transfer medium that we use, and the control of CO2 outside of the incubator can be problematic. If we're concerned about maintenance of optimal conditions, there is no reason not to use oil to help you. So there's only one study here comparing the outcome after aspiration of the embryo directly from a culture drop with or without an oil overlay. So they're going into the dish, taking the embryo. You may have oil on the top or not. There was no difference in clinical pregnancy rates. If you are using oil, you have to have some consideration for it. And the part of the embryo transfer catheter that comes into contact with oil should be rinsed prior to embryo transfer. We used to do it with a center well dish. So the center well would have the embryo transfer media in, oil over the top, and then the outer well of the center well dish just had medium in. We loaded the embryo into the catheter, and then we just moved the inner catheter through the pool of media on the outside. The oil dissipates and is not transferred to the uterine cavity. So it's in most cases, if you can get away without using oil, great. But if your conditions are compromised and you're concerned about maintaining an optimal environment, oil can be your friend, and used correctly doesn't have any negative impact in the outcome of the embryo transfer procedure. So what can affect embryo transfer? What can we do to help in achieve the correct goals? And as you can see here, many of the studies that look at influencing outcome focus on the person doing the transfer, their competence and experience. So to pick some of the key points from these papers that were published in the 2000s. One of the most critical factors affecting success is the technical ability of the person performing the embryo transfer. I think most people would intuitively think that was true. So training becomes key here. So a standardized training protocol allows the achievement within the clinic of similar clinical pregnancy rates across the board. So where we've got multiple people doing embryo transfer, they won't all have identical outcomes, but they should be within a very small window where they're all producing similar results. And that comes down to experience and training from the very beginning and adopting this standardized protocol. As the performance does not increase with experience, the initial training is crucial to standardize the procedure across clinicians. So if you start your training and you don't use an optimal technique, using that suboptimal technique lots and lots of times is not going to increase your success. So the training at the beginning is one of the crucial factors here. As you can see, although pregnancy rates do vary depending on the transferring physician, there are many factors that influence that. The experience of the physician is not the significant variable. So if, as I mentioned before, if they're not trained in the correct way, doing the same thing over and over again, but not doing it optimally, is not going to increase your success. So training at the beginning is vital, and I would extend that to the embryology team as well. Other things in the lab that we have to consider: temperature. We need to maintain the temperature close to 37 as we can. We need to maintain a control on the pH throughout the process. Many embryologists make embryo transfer dishes or make the embryo transfer medium significant time before the embryo transfer. We have to be sure that at the time the embryo goes into that transfer medium, that it's at the correct pH to give the best outcomes. If we don't have correct pH, so if the pH has drifted, that's most likely to be through evaporation, and that will also then affect the osmolality. So these two things go hand in hand, these two parameters. So if you've got evaporation, you're going to affect pH and osmolality. We also need, of course, to maintain sterility and cleanliness. So maintenance of the environment is just as important at embryo transfer as it is during the whole culture procedure. And allowing any of these parameters to drift away from where we want can potentially affect the outcome for the patients. So we're getting towards the end, so I'm just going to talk a little bit more about training and competence in the time that we have left. So it's important that everybody is trained and follows a standard operating procedure. And we need to determine what those competence levels are in each project that we use. So what do we see? Is it a measure of the number of embryos that are retained in the catheter, time from the dish removed from the incubator to the embryo being loaded and transferred, etc. And you can see here, using KPIs and performance indicators are important. We always need to remember, though, if we're using KPIs, we have to use a standard reference population. If we're going to compare individuals, and I think it's important to not only measure the performance of the person doing the embryo transfer, you also need to measure the performance of the embryologist and combinations of the two. So a lab to do that, or a clinic to do that effectively, need to compare like with like. So you need to use a reference population so that the patients themselves don't skew the data. Logging and monitoring of performance outcomes is important. And then you need to determine how many training cycles you go through to achieve that level of competence. So you read this later, but you're going to follow a protocol that's going to do observation, how you're going to set up, doing dummy procedures, and then moving to clinical steps at the end. And then there's what looks a very complicated flow diagram, but in fact is relatively straightforward, and it follows that same pattern. You're going to learn what's important and what's regulated, read all the protocols, watch what people are doing, maybe go to an external training course if you have the chance, and then gradually work your way up until you're doing the whole procedure competently applies to every aspect of the work that we do, and similar training protocols can be used for that. So in summary, embryo transfer, the way I look at it, is one of the most critical procedures that we carry out in the IVF clinic. Excuse me. The clinical team work extremely hard to give us the best quality oocytes coming into the lab. So we've managed and refined stimulation protocols over the years, so that hopefully coming into the lab are high quality oocytes that we can work with. We work extremely hard in the embryology lab to create the best quality chromosomally genetically normal embryos, and what we don't want to do is fall at the last hurdle by not doing an effective embryo transfer. And the embryo transfer procedures involves everybody in the clinic, how you coordinate it, how we communicate between the clinical nursing and embryology team. Don't forget that the time of embryo transfer, embryos are sensitive to fluctuations in their environment. So temperature, pH, and osmolality, they need to be controlled. All the equipment, consumables, and everything alongside needs to be of the highest quality, maintained, serviced, etc. We've mentioned on a number of occasions witnessing and chain of custody, of course, in embryo transfer is just as important. Training, as we've shown, is extremely important. If you're not trained correctly at the beginning, it doesn't matter how many of the procedures you do, you'll always be doing them suboptimally. And there are many best practices around the world. We cannot say there's one. I wish I was able to give a webinar where I could say, everybody, this is what you do, A, B, C, D, E, etc. But there are many variables, and everybody can have their own interpretation of them, as long as they take into account the critical points that need to be done correctly. Okay, so there's more material on our Knowledge Hub on the website. Everybody, of course, if they have time and interest, can go to them. You can see here a webinar on best practice in embryo transfer was done a few years ago now. And then there is a little how-to video on loading an embryo transfer catheter effectively. The PDFs that have all the information, the references that we've used, so they have all the information there if anybody's interested in looking at that. And the last thing to say is thank you so much for your time. I have run over a little bit, which I do apologize, partly because I'm very passionate about the embryo transfer procedure. It needs to be done correctly, effectively, and optimally if we're going to give our patients the best chance of success. So thanks again for listening.